Our next speaker, I'm also very proud to call my friend. Terry Belmont is the Chief Executive Officer and Associate Vice Chancellor for Medical Center Affairs at UC Irvine Medical Center, so we're kind of in your backyard. Terry oversees UCI's Medical Center and its licensed ambulatory facilities. UCI Medical Center has been ranked among America's best hospitals by U.S. News and World Report for 12 consecutive years. I'll be interested in learning how you pulled that off since you didn't join until 2009, but that'll be a... But I'm sure you'll detail that in one of your slides. Since his arrival in 2009, he's led several expansion and renovation projects. For example, in 2010, he initiated the creation of UCI Irvine Health's first integrated strategic plan to create a campus-wide vision for excellence and unified approach to addressing the dynamic changes facing the healthcare industry. I think we can all learn from Terry's experience, so please help me welcome Terry Belmont.
I'm delighted to be here today and see a lot of colleagues and friends and partners, and congratulations to Paul and Margaret for another fine conference. This has gone on a good while, and I always enjoy being a part of it or attending. I want to acknowledge Bob Margolis, and I want to say this in a way that is really instructional for those of us as we look at our careers. Bob and I got to know each other at California Hospital in Los Angeles in the 70s. We were both really kind of starting out. And I was an associate administrator at that time, associate director, and Bob was an internist with a very small group, and they were covering the ED in downtown Los Angeles. And we couldn't get physicians to come in at night to cover the hospital. And therefore, we worked with, and Bob and his small group at the time said, we will take care of that. And that was the beginning of HealthCare Partners. And that was in the 70s. And Bob had an absolute vision of and values about what he should be about and what physicians should be about. And he was in the trenches for years. I mean, absolute years he was in the trenches. And then look what's happening. It's just doggedly staying to your philosophy, your principles, your vision, and your values. And I think, Bob, just congratulations. And it's always great to see you, and I wish we were working together, and I wish I was with DaVita and HealthCare Partners. I tell you. So today, I want to share a little bit from the hospital standpoint, and I'm going to start, I don't know, when you see this, you know, we're Southern California, sure, and that's a fairly aged picture, but I don't know, when you just think about that a minute, what might that mean to you? What might that mean to you? And then we'll talk about it later. By the way, does anybody have a really good guess of what this might mean to you and how it relates to our discussions? I'm not Cheryl, and I'm not gonna let you do it. Once you start, you're gonna get me all day, I know. So, what's that?
Teamwork.
That teamwork, yes?
Balance.
Balance, yeah. Risk? Okay. Okay, well, I'll share at the end. I'll bring this picture up at the end, and I'll tell you how this really pertains to us. So I'm going to talk a little bit about UC Irvine Health. I'm not going to talk about the Affordable Care Act. Everybody's talked about that. And I'm going to talk about healthcare providers and strategic alternatives, focusing on population health management and then value-added service provider. And I'm going to take UC Irvine Health. We'll be a part of this journey because I think we epitomize both academic and possibly non-academic hospitals. So first of all, UC Irvine, we were ranked by Times Higher Education as first in the U.S. and fifth in the world for universities less than 50 years old. That's what UC Irvine has been ranked this past year. We have over 3 million, we serve over 3 million residents here in Orange County. Actually, UC Irvine overall is the second largest employer in the county with over 10,000 employees and almost 2.5 billion in economic impact. UC Irvine, the Academic Health Center, is one of 137 university health centers in the country, university medical centers in the country, and we're one of 5 in Southern California. Our School of Medicine it educates and trains over 400 medical students and 600 residents, multiple fellows, and any meeting I go to that has physicians in the meeting, they've either been trained, have been students, they've been residents, they've been fellows, they've had continuous medical education at UC Irvine. I never can go in Orange County anywhere without having someone. So that's the impact, I think, of UC Irvine Health. And I want to share just a little bit real quickly about UC Irvine Health. And when we say that we developed a strategic plan, I had an outstanding partner in the dean. I have an outstanding partner in the dean of the School of Medicine, Dean Ralph Klayman, who together we felt we needed at the very beginning of our tenure 5 years ago at UC Irvine to develop a strategic plan that encompassed our mission, which is discover, teach, and heal. And so discover, and this is pretty typical for academic health centers, discover, research, teach, of course, and heal. And we also felt, and heal came last, but what our feeling was that once we have patients, then heal comes first. And we've extended the heal to health because UC Irvine Health is what we're about in terms of the health of the population. Our vision, we developed our vision to be among the top 20 academic health centers in the nation. About 3 years ago, we were at 8, and we measure ourselves. We can measure ourselves in research dollars. We can measure ourselves in education in terms of resident matches, student matches, et cetera. And we can measure ourselves from a medical center standpoint from University Hospital Consortium, which we are a part of, and we lead with others. And we can look at our quality measures and our patient satisfaction measures. And so we were about in the 80s about 3 or 4 years ago. We are in the 40s at this point. So that's our journey. And I think the key things in terms of putting all this together, we've had the opportunity to increase in the last 2 years by 18% in terms of our patient discharge, which is still good. It won't be good forever, but right now it is. And why did we do that? What was the mechanism for that? Number one was our ED and opening up our ED even further. Number two was we didn't take a lot of transfers earlier on, and we opened up our transfer center to have community hospitals send their patients that they couldn't handle to our university specialists, and we would give those patients back to the community specialists. And we've gone up from about 300 transfers per year to 1,000 transfers per year. And the third thing, and these are not all exclusive, there's other things that occurred. The third thing is that our National Cancer Institute designated comprehensive cancer center we've expanded in a major way, and we brought on a new medical director, a cancer center director from the East. And and expanding that with the idea of getting clinical trials into the larger population here in Orange County, at least, and then beyond, because only a comprehensive cancer center, NCI designated, can get those clinical trials that are early stage. They're the only ones that can get those out to the community. So those are some of the things that have made a difference for us. So I'm going to leave the Affordable Care Act to others, and I want to go to what are the industry stakeholders doing in response, and to the Affordable Care Act. And by the way, there are, for those of you who didn't get my slides, they are at the table, and they were there before at the break, but they are out there also now. So you know all of these things. You've heard about that. I'm just going to talk on a couple, and one is lowering prices and reducing costs that Dr. Margolis talked about. And some really key areas in that, of course, for us, length of stay, we had a length of stay of over six days per thousand. And that's huge. And we're an academic medical center, yeah, and so should they be higher? Should our costs be higher? I don't know that I can really justify that. I can't justify it to anybody else right now, to any of the payers. But we have decreased our length of stay by 1.2 days so far. That's in working really closely with our physicians. And I know that's what hospitals continue to do. We've also gone to case rates in terms of our payment mechanism, so we can encourage ourselves to really do things, look at our resources in a way that we haven't looked at before. We've also, we've reduced variation, both within a physician's practice and among physicians' practices. And it's not because we have physicians that are faculty who are employees of the University of California. It's because we've developed a partnership that really impacts our clinical enterprise. They know what they do impacts our clinical enterprise. And so it's the partnership with physicians, whether it's an employed partnership or whether it's and that's where a lot of that is going, or a strong relationship that's historic, like HealthCare Partners has a strong relationship with a number of providers, and they work together. And so that's how the costs are being done. And I think the other one I want to mention, just as the bottom one, and making information more portable and transparent. And, of course, what was heard earlier today, all the mobile devices, all the opportunities to monitor patients in the future, that's going to make a huge impact on the costs. Now, I just want to talk about two organizational models that I think are emerging. And so I like the term population health in a broad term. And population health management in a broad term really relates to not only the care that's being delivered, but it's about epidemiological issues. It's about the health of a population. It's about preventing. It's how healthy is the population. And then there's the care delivery model, whether it's horizontal or vertical. And so I like the broad term. And this slide reflects the broad term in the upper areas, and then how you care in the lower areas. And I think most systems are not there in the broad area. Most organizations are not there. There are some, we have a lot of divergence, and there's several systems, and Dr. Margolis talked about a few in California that made tremendous progress, but we're not there. So the question is, in the broad term of population health management, and is it the incentives, as Bob said, or what's going to pull us there? And my personal feeling is, my prediction is, it's going to be 5 to 10 years, we will have organizations who are able to population manage in the broad sense. However, my focus at this point is just going to be more on the care delivery part. And I want to share a new population taxonomy. And I'm going to have to go through this fairly rapidly. And again, I encourage you, if you don't have my slides, to get them. And this comes from the University Hospital Consortium Research Institute. And this was just presented to us, and we, many of the CEOs are on the board of the governing board of the UHC. And I want to share this taxonomy because it really is talking about 4 different levels of patients. And it's talking about the healthy majority, that's and I'll go one by one on that. So first there's I'm going to go back. The healthy majority is, that's the majority of the population. And their spending is just on one event. It's an event. It's not a process, it's an event. And so there's the opportunities for saving in that kind of, with that kind of population is not very great. Then there's the asymptomatic early chronic conditions like diabetes, hypertension, early CHF. And there's modest spending, long-term risk for decompensation. And there's still limited savings potential until the disease progresses. The savings potential is really trying to keep them to the progression, but really, again, not a lot of savings. But then full onset chronic diseases like CHF, COPD, chronic back pain, Typical episode costs $20,000 to $45,000. So we estimate there's 20 to 40% opportunity for savings through serial stabilization. And then finally, complete episodes, and that's cancers, strokes, transplants, individuals with those dual eligibles. A typical episode for these are $50,000 to $150,000. And so there's a 30 to 40% opportunity for savings if variation can be controlled in that. So the strategies for each of these 4 populations is really different. And on this slide, this just shows what would be the strategy for the healthy population. And it's really dealing with most ad hoc needs with low-cost, early access resources. Going to the asymptomatic, well, it's choose primary care physicians with skill in managing chronic conditions, pre-chronic conditions. And the third is full onset chronic diseases, and again, that's focus on serial stabilization, medical specialty home, not just the primary care home, medical specialty home, and then so on to complete episodes. And you can see what that is there in reducing variation, improving adherence to standards, and excel at end-of-life care. So that's I think, a way that we're looking at this point. So then let's address positioning as a value-added service provider. That's another approach. And you can see that approach, and that's just a few of the items that value-added service. And what really makes a value-added service provider successful is a differentiation. And the differentiation, there are a lot of different attributes one can decide. And as I'm talking to my CEO friends throughout not only California but elsewhere, each organization is in such a different place. And so, and most of them, particularly the individual hospitals, are not able to get into population health management. And so they really are looking at what is their value added in their community, in their region. And they're looking at these different alternatives in terms of being value added. So I'd like to just share a little bit about UC Irvine Health's, our strategy in terms of these areas. And number one, we had no primary care in our organization, and we have to be a part of population health. If, as an educational institution, we must be a part of population health. We need to learn how to do it. We need to learn how to do it well, and we need to teach others how to do it as physicians are coming through their education. And so that, as we looked in the community, looked in the region, and given that we had very few primary care physicians, we made the decision to go out and look at who might we partner with to be able to bring in the expertise in terms of population health management. And we talked to a lot of different organizations, both in the county and outside of the county. And as you are quite aware, we found a wonderful affiliation in primary care affiliation with Memorial Care and the Memorial Care Medical Foundation. And that is moving forward. We're very excited about where we are with that. Our goal, our forecast is to have 50,000 members in our area that we will have the opportunity to population health manage, and to do that in a manner that will be wonderful for the community and will help us be educational to our physicians in the future. The other side of things is that's only a primary care affiliation. The other part of what we do is that we have our tertiary quaternary services. And our tertiary quaternary services are, we've focused those very specifically, and we are expanding those to everyone within the county. And I mentioned our growth, our 18% growth. The part of the reason that we're growing is it's not at the expense of other facilities within Orange County. It's the fact that we had so many individuals within Orange County who left the county to go elsewhere, to one of the other 5 academic medical centers, because we weren't as friendly. Either from a physician standpoint or from a facility standpoint, we weren't as friendly. And That growth has come both through, and through that tertiary referral care that we're able to keep patients within Orange County. And that continues, but 30% of our volume is tertiary quaternary. And there's no way that we can maintain our mission by just that, which is why we also went into the population health. I believe our tertiary quaternary volume will continue to grow, and that is a challenge in terms of this environment. But that's been our strategy. Not for the faint of heart. That's a quote from Robert Searling, who is he's the Chief Ministry Officer for the Order of St. Francis Medical Center out of Chicago. And he talks about population. They've been very, very involved, heavily involved in population health. Almost over a majority of their volume will be in that kind of setting in the very near future, he says. So it's a tough field, takes real strong leadership and partnership. So I'm gonna pass there a couple. No, I'm gonna go back for just a minute. I do have that here, but Jay has not given me the last. There he goes. But all health, consider it given, he said. All right. All health systems will not be in population health management. PHM is a strategy. I don't think that is a strategy. And I think I'm just going to go to this. So what does this mean? Well, what this means to me is that, first of all, as organizations, as we're kind of somewhat into the Affordable Care Act, we are moving, the incentives are moving slowly in some ways, fast in others, but we can't go too slow. We have to change our organization, but we can't change it too fast, or we're going to hurt ourselves. And so that's like surfing a wave. If you get too far ahead of the wave, then you crash. If you get too far behind the wave, then you're left behind. So that's one. And then the other, good buddy of mine was a tandem surfer, and balancing. I think it's a real balancing act, and that you can't find a better balancing act than a tandem surfer. Thank you very much.